Good evening, everyone. I'm Dr. Asha, the clinical head of London College of Clinical Hypnosis Asia, and it's truly my pleasure to welcome all of you to today's session. And we are very honored to actually have with us today esteemed speaker who brings with him a lot of knowledge, experience, and also definitely clinical expertise. So it is my privilege to introduce Dr. Tong, very highly accomplished psychiatrist, registered under the National Specialist Registry with the Malaysian Medical Council, and he currently serves as a senior medical lecturer at the Faculty of Psychiatric and Health Sciences in UMS, and where he's also the head of Department of Psychiatric and Psychological Health. So, ladies and gentlemen, please join me in welcoming Dr. Tong.
All right. Okay, let's kickstart this. Welcome everyone. Hi, my name is Dr. Thong, and today I'm going to give a talk about how mental well-being impacts your practice. And I do mean by this when speaking from a psychiatrist point of view is how it will involve around how I explain about how this mental health aspect will be the determinant factor about how a therapy or even hypnotherapy, how it would affect the effectiveness of hypnotherapy, and as well as I will share some of the tips and guides about how to actually investigate or even do some assessments about mental health well-being. Okay, so let's go next. A little bit about me. Yeah, I thank you, Asha, for the kind introduction. Yes, I'm a psychiatrist registered under the NSR, and also currently a senior medical lecturer under the Faculty of Medicine and Health Sciences. I'm a Department of Psychiatry and Psychological Health in University of Sabah. And also I'm currently the head of Department of Psychiatry and Psychological Health. I'm a clinical hypnotherapist, a graduate from LCCH with a specialist certificate under the medical pathway. And also I have a clinical supervision certificate. Anyone that is interested to get some supervision done for clinical hypnotherapy, of course, I am open for supervision, and it is accredited by BSCH as well. So I'm also a DPT practitioner, skill practitioner, intermediate level, and I'm a member of a Royal College of Psychiatrists from the UK. What will we learn tonight? Yeah, how to recognize key signs of mental distress, and how to learn a bit about how clinical hypnotherapy can enhance emotional regulation and reduce psychosomatic symptoms. We will also discuss regarding how actually this clinical hypnotherapy can be implemented in clinical practice. I suppose that a lot of participants may be doctors. Yeah, if it's not doctors, it actually, I would say that clinical hypnotherapy can also be beneficial for occupational therapists, nurses, medical assistant, a lot of healthcare professionals. So yeah, we can discuss more about that later. Next. So the first subtopic today, what matters in terms of mental well-being, is a very big aspect of what we call well-being, yeah, psychological well-being. But what exactly within it that actually matters to our clinical outcome? So far, yeah, for those who are therapists, yeah, I do think that a lot of therapists know these rules, yeah. So the most important thing, yeah, as a psychotherapist, counselors, or anything, yeah, from the psychiatry side, we always say this, yeah. If you wish to do psychotherapy, you have to make sure that your patient has no high-risk behavior. For example, suicidality and homicidality, or even sort of a psychosis, yeah. Those conditions, it requires a higher form of treatment. It may require pharmacological intervention, like we have to start medicine, and there may be a need for medical intervention as well. So in terms of this kind of what we call high-risk patients, if they are previously not assessed by a doctor, a medical practitioner, please refrain from doing the psychotherapy unless it is ordered by a certified clinician. Yeah, he has already done the assessment. All right. And you have to make sure that before your therapy session, if you can, yeah, as a clinician myself, we are required to do a vital sign checking as well as the general medical side, like an assessment first, to make sure that the patient is actually void of any acute medical conditions that require intervention during the session. Because your psychotherapy session, usually it will last for an hour. So you have to make sure that the patient is actually medically stable during that hour. so that there's no further complications. Okay. Yeah, like I said, the last one, if there is a suspicion, yeah, if suspect of mental illness. When I say mental illness, it includes a lot of like psychosis, mood disorders, or even when you encounter like something that is a bit unusual that you are not sure about, yeah, please do not hesitate to actually counsel the patient for a proper psychological assessment or even a medical assessment first, yeah, and to confirm that this patient actually would benefit from the psychotherapy itself. Yeah, actually, it did happen in my practice at one time that there is a patient that is very eager that come to our clinic and ask for psychotherapy, ask for a counseling session. While we noticed that the his blood pressure is 190 over 110. Yeah. As a clinician, I do know that what you are thinking about. Yeah. 190 over 110 with this patient has headaches and having dizziness. So this kind of a patient, it is kind of dangerous if we want to go through any psychotherapy. We actually refuse to do the therapy session during that time and ask for the patient to go to have a proper checkup first for his general health. So yeah, do keep that in mind. Yeah. All right. Okay. So what is mental health well-being? All right. To sum it. Okay. Well-being of a person, it divides into the physical side and the mental side. All right. And for mental illness, we do regard that mental illness, it has the same nature as having a physical illness. It may happen without a cause, like just like you having a headache or even a sore throat and things like that. There might sometimes that it's just that you are maybe not that well during that moment. Yeah, you're feeling a bit down. So it actually these two, the physical health and the mental health, actually they are really related to each other. So when we look at mental health, yeah, even within psychiatry practice, we have to look at the biological side of things, yeah, aside from the psychological. And as well as there's a lot of psychiatry intervention, mental health intervention. It involves the environmental changes as well. Because, for example, yeah, I have a patient that we require to do some home visit during in the past. He's mentally ill. But when we go to the house, yeah, the house is not in a very good condition. He started to hoard a lot of rubbish around the house, and he has difficulty finding a place to sleep even. So that kind of an environment in our practice, we call it this not therapy, is a very not therapeutic environment. So we actually during the time have to organize some sort of like a cleanup for the patient to organize back his living condition, and his condition has slightly improved. So in terms of this mental health, we do have to look at the physical health side of things. Do always keep in mind, yeah, aside from the psychological that you are trying to check about their coping mechanisms, their social skill, their self-esteem and things like that, you also have to look at the biological and also the environmental factor as well, okay, in your assessment. All right. So in terms of what does it mean by someone being mentally well, yeah, it involves, in this term, we will be looking at how stable is the psychological part of things, their resilience, yeah, meaning that how they actually tolerate stress, their capacity or their ability to regulate emotions and cope with illness. Actually, everyone will have a different baseline of mental health. It can be trained, yeah, it can be trained, it can be learned, and it can become a habit. It can be related to personality as well. Yeah. So to say that someone is mentally well or even resilient or even stable, yeah, we actually wouldn't have a very clear gauge about what sort of ability that they must able to achieve. Everyone has different strength, but we would say that, okay, one is that they are absent of mental illness, and yeah, we will also say that the patient is mentally stable and mentally well to achieve their supposed functioning during that time, meaning that they are able to do what they need to do or even what they want to do, yeah, in their daily life, void of any like difficulties in terms of the impact from the psychological side. All right. Okay. Next. So this is just some examples, yeah, for among any clinicians over here, how actually mental health can be affected by the medical side of things. Okay, actually my interest is also neuropsychiatry and also neuroendocrinology. So Cortisol is actually a very interesting hormone inside our body. It actually can make someone quite anxious or even feeling good or even feel depressed. And also cortisol actually regulates a lot of like brain activity as well as your cellular activity inside your body. So when you are stressed, when there is a cortisol level that's a bit too high in your body, it actually cause your wound to heal slower. When someone actually are in pain, and I think that a lot of orthopedicians will agree with me, if the patient is actually mentally unwell or even depressed during that moment, you might see the wound is healing not that good, in your practice. Okay, down at the second one, inflammatory cytokines. That one, when we are having some inflammation around in our body, depression can be also, it can be the one that cause, there have been studies that says that inflammation is the one that cause depression and vice versa. So when we have a lot of these inflammatory markers inside the body, there's a lot of other illnesses that can be arise from there. For one of it is cardiac issues. And also this actually is kind of new, I would say, a new horizon to be explored by psychiatry, where these cardiac issues, when coupled with depression, there is so many factors around, like how the medicine can actually act on the cardiac activity, and also how would rehabilitation works in terms of when the patient is depressed, the cardiac rehabilitation. So all this can actually contribute to the worsening. When someone having cardiac issues, it can worsen the depression, like when they have a profound lifestyle changes and things like that. So the one thing that we learn, in our practice is actually when there is a post myocardial infarct depression, post heart attack depression, the mortality actually increased by 5-fold compared to the usual depressed patient. So there's something interesting right there happening. Of course, the last one, you do know that when we are anxious, there's a sympathetic increase in sympathetic drive, increased heart rate, and also your blood pumps faster and your breathing is faster. Actually, it can cause a lot of issues like hypertension and arrhythmias. Okay, this is something about what I said earlier also. Okay. And this is just a point to make, is that physical illness actually matters a lot in terms of when we look into the mental illness of things. And do take a note on this, is that when we are assessing suicide, when we are assessing a suicidality of patients, having any chronic illness is actually one of the contributing factors to suicide behavior. So there is a need to actually, for any therapists or even like psychiatrists, to always know that there is a medical condition, whether there is a medical condition happening comorbidly at the back, and also what sort of a medicine that they are taking. For example, just one for example, for clinicians out there, everyone would know steroids. If there's too much of a steroid, you may have changes in mood, causing mood disorders as well as psychosis. Steroids it can be one of the factor. Even anti-TB medication, one of it, I think, is isoniazid, can cause psychosis. So these medicines, actually there are medicines that actually can easily cause psychosis. Parkinson medicine, levodopa, can cause psychosis. So do take note on the medicine things. Next. Okay. So in terms of treatment adherence as well, like I said, one relate to each other. And then even in WHO, there was once a sentence that come out that actually, I would say, it becomes something like a slogan for us psychiatrists, just to show how proud we are at some point. There is no health without mental health, meaning that there is a poor recognition of a need for treatment when someone is actually mentally unwell. Like actually, a lot of patients, when they are mentally unwell, they lose the insight towards the need of treatment. For example, when a patient is bipolar manic, 90% of them lose their insight. So with poor mental health, the risk of a patient being non-compliant to the treatment regime will be higher. And as well as when they are mentally unwell, during your session, a lot of psychological therapies do require your patient to be alert and attentive, and actually has a good, what we call, psychological mindfulness. So when they are mentally unwell, it actually lowers their perception about the things, about the therapies, what they're trying to deliver during the therapy. Also, of course, there's a risk of these missed follow-ups, poor medication compliance, drop out for the therapy. Yeah. So before your therapy starts, do make sure that the patient is actually physically well as mentally well. And also this thing. All right. I do say I would say this, okay, to all the clinicians out there. Yeah, you might find yourself at even more stress when you're trying to counsel a sick patient because when the patient is actually sick, there would be a lot more effort. Like I said, there's a difficulty in terms of what to make the patient understand what you're trying to deliver. So in terms of when they are mentally unwell, it makes your job actually harder, and you may, yeah, I would say may, but actually a lot of people might have experienced this. You may get frustrated during your session with someone that is mentally unwell. And that is why we psychiatrists, we have 14 days of extra leave compared to other clinicians. Just to say this is that when the patient is mentally unwell, it actually makes your job harder, and it is hard to build rapport with the patient. And in psychotherapy, there's a very big factor, especially in clinical hypnotherapy. Is about familiarity and rapport, what we call it. How much the patient actually trusts you about and actually willing to learn from you. So when they are actually physically and mentally well, there is this kind of a healthy, what we call a therapeutic relationship between the therapist and the patient can be built more easily compared to when they are unwell. Yeah. Okay. Next. All right. Key signs of mental distress. A bit technical, sudah. Okay, we are going a bit technical here. Yep. This one. I think we already mentioned that when LCCH contacted me to want to present about this. I was thinking about what sort of an audience that I have. So I would suppose that a lot of you will be interested in psychotherapy, and some of you will be clinicians. Okay. So I would teach a bit about what actually in my practice, how we are looking at our clients or even the patient, how we do this mental state examination. So it actually is a long list of this. What we are actually during that, I would say 1 hour when we talk to our client, all the time we are observing all of this. Yeah, their appearance, their behavior, their motto, their speech, their mood, affect, thought, their thought disorders, any perception disorders, any cognition issues, any judgmental issues, and any insight issues. So it is a long list. Yeah, I would not expect this everyone to fully understand how to do this in this 1 hour, because even my medical student would take what 6 weeks to fully learn this. So it's just to give you an idea about. I would focus on things that actually a bit more, I would say, easier to catch. Yeah, for you all. Next. All right. So the most important thing, yeah, during your therapy, yeah, you might deal a lot with cases of depression. Okay, but do take it in mind. There are some depression which is severe in nature, yeah, severe ones, they would present to you not like the patient is not like a sad person. I have seen patient that is highly suicidal that is not showing any sadness. Okay. So, yeah, please do bear in mind that you have to ask the patient, how are you feeling today? Yeah. And I usually do this at the start of my session. How are you feeling today? Just throw in this open-ended question at the start to allow them to express themselves. Yeah. They might not show you the tears, they might not show you even the frown, but they just get the chance of getting them to have the chance to tell you that they are actually sad or what they are actually feeling. All right. And also during your consultation, please observe their behavior. Observe what they do and how they do it, even how they behave around you. For example, if you have some patient that comes in, yeah, feeling that he's actually sad, more than often you will see them be like I written here, withdrawn. They will talk less. They might not look at you in the eye. Things like that. Do observe their behavior. Yeah. The other term that I written here, hopelessness. Yeah. This word hopelessness is actually a key component of suicidal assessment. Yeah. So do ask for this. Yeah. When you are doing your initial screening or even all the time, if you are worried about it, do ask is that do they feel that there is no hope in the future? That is usually the sentence lah. Do you have sometimes feel that there's no hope for the future? This kind of a question. So during your assessment, don't just rely on your eyes. If you are not sure, just ask. You are the therapist, you are the clinician. It's your job to actually find out about these important parts of things. Yeah. Do ask the patient. And they are seeing you for clinical consultations. They are seeing you for your opinion. So it is okay for you to ask. Yeah. And to if you wish to check for suicide and you think that there's something a bit you need, if you feel that ever there is a question mark in your head that actually tells you this patient might be a bit suicidal, do ask the question. I'm sorry that I have to ask this. Do you feel like there is actually any thoughts about harming yourself? Do ask this question. If you are the therapist, if you are the clinician, have a knack, even train yourself to ask these questions, because this is actually, I would say, it is quite scary when you first ask it. Yeah, even some of the clinicians, they might find this a bit weird to ask. Yeah, but I can assure you, if you are into psychotherapy, if you are into mental health practice, this will be your bread and butter. Yeah, you will get more and more familiar in asking these questions as long as you train yourself. Yeah, and you will get better at it. Yeah, I can even ask this question with a very empathetic face for 100 times, empathetic face for 100 times in a day. It's almost like an instinct, sudah. Okay, so okay, the others, yeah, anxiety, excessive anxiety. The patient is if this is a first section, I would say that everyone will be anxious to see a psychiatrist. That one I totally understand. But if the patient is restless, like fidgety, always want to walk up and down, something is weird. You have to check about, is there any medical condition and things like that. Yeah. Emotional ability, tearfulness during consultation, tiba-tiba laugh out loud. Yeah. This is a bit weird. If someone is sad, it's sad. But if you notice that there is a patient that always tiba-tiba laugh and tiba-tiba cry and suddenly talks a lot, that's actually a sign of bipolar depression, bipolar disorder. Like the patient is manic, labile. Yeah. So his mood will swing so fast that he himself actually don't realize that. Sometimes they don't realize this. That actually, something to look for. Difficulty concentrating, indecisiveness. Okay, this one, you have to dig a bit deeper. Is it whether that this patient having memory problems, cognitive problems, or actually difficulty concentrating, indecisiveness? I do see it in schizophrenia. Like they are disturbed by the hallucinations and delusions. They have difficulty actually concentrating about what you're trying to say. This one, if you see it, difficulty concentrating, indecisiveness. If a therapist see this, it's almost like a red flag macam tu. Something is, because if you have a client that is having difficulty concentrating about what you are trying to say, the sessions might not be helpful during that time because you need their attention during the therapy sessions. So do find out why they are having difficulty concentrating. This one, the other things that you have to look for, when I say that, okay, one is of course the face to face, the one that you can see in front of your eyes, the consultation period. Yeah, during your consultation, the mental state examination is that what you are looking at the patient, how are they behaving. There are other parts of this as well, okay, that you have to keep in mind, that throughout your session, your treatment session, how is the patient behavior throughout your treatment session, not just in front of you. Okay, do they suddenly would cancel appointment? Just on the whim. Tiba-tiba apa tu, just tell that they don't want to come. A lot of try to I have encountered this patient before that actually she doesn't want to discuss what the therapist wish to discuss. She just wants to discuss what she wants to discuss. There are some patients that is like that. Then the other part is that when the patient says that he's getting well, he's getting better and better. Okay, there's this also another case. The patient is getting better and better. He says during the consultation, but the family member later tells me that, doctor, he's actually not. He started to miss out. He started to not going to work. He doesn't take care of himself as inside the house, and he actually is getting worse. The functioning, in the end, your treatment, the effectiveness of your treatment is not about what the patient only tells you, I'm feeling better. That is just one. The other thing is that, is he able to function as he is supposed to be? That should be your benchmark. The one that determines whether he is well well person or not. Yeah, yeah, he's functioning well. Okay, so if something like that happened, you have to look back. Actually, what is the patient actually getting worse? And yeah, further investigation has to be done. All right. The fourth one, yes, he come and sees you every time he come and see you. Yeah, just want to see you, but he started to withdraw socially now and neglecting, especially in self care. This one and the second and the third one is actually almost the same. It's like the functioning itself is deteriorating. Social skill and taking care of self is actually a functioning of a person. So if this is suddenly getting worse, yeah, you have to look back. What is there something wrong in your treatment as well? Yeah. Okay. Next. All right. So in the end, yeah, I'm a clinician. So this should be, if any clinician over here, please always try to look for this as well. Physical presentations, yeah, your somatic side of things. Aside from asking about how they feel and things like that, do look for any physical signs as well. For example, headaches, yeah, GI upset, chronic pain, fatigue is very highly associated with depression because your pain center and your depression center, the pathway, the neurons are actually the same. When the patient is depressed, they are more susceptible to pain. Mm-hmm. Okay. Any weight changes? Yeah, this one is a patient getting thinner and thinner. Like a depressed patient. Actually, recently I received a case that actually the old age patient started to lose weight, like 10 kilos over sorry 10 to 20 kilos over a course of a year. That is a severe depression case lah. So yeah, you have to look for that as well. Sleep is a very good indicator. Sleep, once my mentor actually told me about this, is that if you wish to know whether the patient actually is going into relapse, like getting worse in their illness, do ask about their sleep. If they started losing sleep, that is the one indication that he might not be doing that well. Yeah, before any symptoms starts in lah. So do have a knack of checking the patient. Are you sleeping well? Just ask that kind of question. All right. So the what tachycardia, sweating, and all this, like the physical signs, yeah, do look for that because sometimes it can be related to your psychological well-being, like anxiety. All of that can be causing that. But yeah, as a clinician, you do know that it also can suggest other things. Tachycardia, it can be medicine induced. It can be what? It can be heart-related issues, sweating, yeah, like things like polydipsia and things like that. Yeah, do have a keen eye on these things. My and there's a lot of teachers in my life. So another teacher of me told me this. Yeah, to become a psychiatrist, when you become a psychiatrist, always remember your medical. Yeah. So a psychiatrist is not a privilege to lose your medical knowledge. Yeah, that sentence I remember until now is that if I am a psychiatrist, I have to be a medical doctor first. I have to master medical first. Then I become a psychiatrist. So yeah, for clinicians, do remember this. Yeah, if you are venture into psychotherapy, keep your medical knowledge and skill. Yeah, these are the red flags in the clinical setting. Okay, first, suicidality. Always in the back of your mind have this thought is that can my client actually be suicidal? Because having suicidality, if you are a psychiatrist, okay, you can decide for yourself. But if you are not, yeah, please do refer them for assessment by a psychiatrist or a proper medical practitioner. Then allow them to discuss with the patient and decide whether the psychotherapy is actually appropriate for the patient. Okay, severe functional decline is actually the prerequisite criteria for any disorders. When we say disorders, meaning that the patient is not functioning well. So if you are having some patient that you recognize that they are actually not able to do what they are supposed to do, yeah, it means that they might be ill and require like further treatment lah. Okay, and especially in those cases that the function decline is so severe and so fast that it's actually a bit worrying. For example, suddenly in a month the patient not able to go to school and not able to talk to people in a month. Yeah, that actually happened to a case of mine that has encephalitis, the infection of the brain that presents as psychosis. So it's a what? Yeah, something to bear in mind. Disproportionate anxiety, yeah. Any substance misuse. Do ask whether your patient is misusing substance. One is substance and their medicine. What medicine am I talking about? The biggest culprit in my practice is sleeping pills. Yeah. And in clinical hypnotherapy, sleeping pills is a big issue because yeah, you're trying to make the patient relax, but the patient is on sleeping pills. So it actually, yeah, is a I do encounter a lot of difficulties when try to do that. Yeah. With what we call this sleeping pill dependent patients. Right? Psychosis, unusual behavior. Yeah, the last one. If they started speaking irrelevantly or having some unusual behavior, when you feel weird, do refer for consultation. Okay, next. All right, the other thing, just to show you all how deep this rabbit hole can go when we say that psychosis, when we talk about psychosis. Okay, so in 2018, this is one of my mentor that actually tells me the eyes doesn't see what the mind doesn't know. Yes, you have to have a keen have a recognition about what are these for what is actually being mentioned, what is delusion, obsession, yeah, what is flight of ideas and things like that. But as a general rule of thumb, yeah, if the patient starting to speak weirdly, that it then speak doesn't make sense, do refer for psychiatric assessment, yeah, because how a psychiatrist or how we assess the thoughts of a person is actually looking at how they speak, what they speak, and how they speak. Okay. When we look at the content, we are actually looking at what they're telling us. Like, is there any unusual thoughts like delusion, obsession, any suicidal ideation? That is the content. What are they talking about? How are they talking? When we are looking at how a person talks, we can actually get the idea about what is their thought process, what it means by the flow of thought. Like, do they talk when we say derailment, meaning that they are like they couldn't stay on one topic, they would just go everywhere. Yeah. Flight of ideas is like actually they can't stop their thoughts from racing. That is a manic symptom. Bipolar disorder, manic symptom. They couldn't stop thinking. Okay. And the last one, the form of thought, this is a bit technical. Yeah. We do observe this in schizophrenia, where the patient, when okay, just an example, thought insertion, meaning that they actually think that other people can put thoughts into them. Passivity, meaning that they actually think that their own thought is not their own. They have this feeling. That is why it's like I said, the eyes doesn't see what the mind doesn't know. But that is why do be a more alert when the patient starting to tell you things that actually you think that yeah, it is a bit unusual. It doesn't make sense. Yeah. When they start doing that, do refer to for consultation lah. Yeah. If you're a psychiatrist, you would understand what I'm talking about. Clinical hypnotherapy in clinical practice. Okay. What what actually work and what would not? What is clinical hypnotherapy? I would say this for all the psychotherapy, yeah, for almost the older generation psychotherapy like psychodynamic or even CBT, the usual ones, yeah, CBT, they require a lot of like engagement with the conscious mind, meaning that there's a lot of analytical logic perception and things like that. Yeah. Hypnotherapy, when I say that CBT is older, hypnotherapy is actually way older. Yeah. It actually started off by this French, I would say some kind of a therapist. Yeah. During that time, he used art of mesmerism, meaning that they use words, or even at some point during the older culture, they do perceive hypnosis as an art of mesmerizing. Dalam bahasa Melayu, pukau. Yeah. What does it actually do? Yeah. What is actually the core component of it is that the hypnotherapists, we would rarely be interested in your conscious mind. We are not. We don't think that. Yeah. We don't think that the analytical part of your brain would be your problem. Actually, when you really think about things, like what am I supposed to do? What is the best course of action? What when you analyze the situation, your mind will tell you the best answer. But what makes you do the opposite? Your deep down, yeah, the deeper down of your mind, there is this subconscious or even the unconscious level that actually is the fundamental, the nature of humanity. Yeah, the fear, your memories, your fears, your urges, your yearnings. Those are the things that actually, at some point, we would say that it is suppressed by the analytical mind. Yeah, where everyone I would say this like if someone that is void of emotions and there is void of yearning and urges, it would just be like a robot and do like ChatGPT, just give you the best answer always. Yeah. Occasionally lie about things and try to trick you. Yeah. Even ChatGPT does that. But what makes us human? What makes us feel the pain, the sorrow, sadness is actually what is deeper down. So clinical hypnotherapy is a form of therapy that we look into that level of things. We skip past the conscious level. Yeah. How to do that? We are using deep relaxation, intense focus, deep relaxation, and also suggestion. Suggestions is like some. If anyone have seen this movie called Inception, yeah, by Leonardo DiCaprio. Yes, yeah, the movie is interesting. It actually tells a lot of hypnotherapy kind of a concept of things. Yeah, the idea is that as you go down into your dreams, yeah, I think everyone dreams. Yeah, so in your dream, you might find something weird. Yeah, why did I dream about something? But your mind, the dream, how dream is being manifest is actually your subconscious level trying to put ideas or even words or even some concept into the urges and yearnings that you have. For example, yeah, someone that dreams that he's being chased by a lion in his dream. I do have a patient that reports this. He says that in his dream he feels like he's being always being chased, whether by a lion, by a monster, and things like that. And every time when the lion almost want to catch him, he will wake up. Yeah, he's having difficulty at work with his boss. Like something that is fearful that's coming at him. There's something that is worried that he mismanaged something at work. He is so worried that something is coming at him. So this kind of a emotion, the brain is trying to manifest it in ways that, yeah, it in ways that they couldn't put it into words. Yeah, in your subconscious and unconscious level, things become creative. Things become, I would say, even at some point, chaotic that might not be expressed as words. And that is why hypnotherapy, the clinical hypnotherapy can do is that we use suggestions to tap into those kind of thinking, those kind of thoughts or even concept that your brain has. Okay, next. So what is it for? The biggest evidence that we have, pain management. Yeah, by going into intense focus, it numbs down the pain. It slows down the pain. PTSD, there's a lot of what even EMDR can couple with therapy for PTSD. Depression, anxiety, me myself have used this very often. Insomnia, that is very helpful. Eating disorders, we don't need more evidence on that. Medical and surgical procedures, it involves the pain management side of things. Yeah. Cancer treatment side effects, psychosomatic side effects, and some wound healing. Even there are cases that even when my wife is giving birth, I actually trying to hypnotize her during childbirth to make the process easier. Okay, weight control and also stop smoking. There is evidence for that. Why is it not for? Please avoid psychotic patient, suicidal patient, antisocial personality disorder, meaning that the patient has no empathy, and yeah, actually they are. I would say that in the more layman term is evil person. Also, factitious malingering, meaning that the patient is actually there, they are not telling the truth. Is yeah, that's the clinical terms of things. Next, the suitability. What makes a person suitable? A lot of factors. Yeah, you have to look at whether they have hearing impairment, because a lot of times it's about your voice. Yeah, about them listening to you. Any medical condition, any medication, like I said, the sleeping pills. Yeah, the language that the therapist is familiar at and what the patient is familiar at. I can do hypnotherapy using English a lot, Chinese a bit better. Malay, I would need to think about how to translate in my mind, then baru I can talk. Yeah. So that's the language part of things. Familiarity rapport. The more your patient trusts you, the better they can receive it. Okay. And lastly, is your patient motivated to go through the session? If they are having doubts, it's slightly harder. This is actually a paper that recently published, a meta-analysis that looks at the emotion regulation side of things. So the biggest, I would say, contribution for clinical hypnotherapy, the biggest evidence is that it reduces anxiety, because a lot of times it's involved relaxation and imagination, mindfulness practices. Yeah. So it reduces anxiety. reduce the stress reactivity, meaning that the patient can be able to control themselves better, and it builds up a new coping skill in your patient. And yeah, there is a way that we do it in clinical hypnotherapy, that we reframe, we restructure the maladaptive thoughts. This one is an incorporation of CBT techniques, as well as some clinical hypnotherapy suggestions that we can do. Like sort of like it enhanced the CBT techniques that is being used. All right. Next. All right. So psychosomatic symptoms for, like I said, pain management is really good. That one has a lot of evidence on that. You guys can read it out on this. Yeah. GI disorders, especially the irritable bowel syndrome. Yeah. It actually helps them in controlling the bowel habits, and also reduce the discomfort. Okay. Headaches and migraines, there is a need for the further study on this, because there's a lot of heterogeneity about the nature of the headache, like what kind of a headache that we are talking about. So we have to look at but mild headaches and things like that, there's some evidence on it lah. It can help. All right. Stress related flare reduction, like if there is a condition, for example, some eczema, eczema that actually can be worsened due to stress. By managing the stress, it can help with the situation. Simple as that. Okay. These are some clinical evidence. Okay. Some papers. Those who are interested, you guys can look it up. Like I said, the pain management memang meta-analysis pun sudah keluar. So something interesting lah. Okay. In clinical practice, how we do it. How I do it. One, I can do it as standalone therapy, just clinical hypnotherapy. Number two, I can do it in couple with another form of a psychotherapy. For example, I have interest in doing this. Not interest, actually, I've done this a lot of times. Coupling it with ACT, acceptance commitments therapy. It's a new form of therapy that looks into values, and actually at some level it actually goes to the subconscious level. It's a new form of therapy that uses metaphor as well. So I do find that clinical hypnotherapy and ACT and this acceptance commitment therapy can really go hand in hand. So this is one example. The other one is, of course, CBT. Yeah, CBT can be coupled with hypnotherapy as well. Basically, these two, is a very good couple, especially ACT. I would say ACT is the best. And I have to say this. Sorry, when you learn clinical hypnotherapy, don't learn it just to do the therapy itself. Try to learn it how to communicate with others, because communication, it involves voices and what you're actually doing, and how you suggest something to a person. That is called suggestion. So if you learn hypnotherapy, do learn the techniques to be used in your daily life. How I speak to my patient, or even how I speak to you, or even my students, there are some element of hypnotherapy there. Yeah. So it will be interesting. But to elaborate on this, I would need you guys to actually have some first sessions to learn a bit about the basics about clinical hypnotherapy first. Okay. Next. All right. So in the hospital, I have done this pre-surgical anxiety reduction. Try to relax the patient, giving some suggestion, some induction to calm them down. Yeah. There are cases even done in Malaysia, that localized anesthesia, not generalized. Okay. Localized anesthesia done only using hypnosis. Yeah. By Dr. Allen, one of the lecturers there. Yeah. So a lot of dental procedures or hand surgery during that time was done. So it is possible. Yeah, this is a promising ground. Okay, oncology, like during chemotherapy, to reduce nausea, let the attention going throughout the chemotherapy also can help. Like labor, childbirth, things like that, it can help us as well. For psychiatry, you can use it. Yeah, I would say, aside from the major psychiatric illness that requires medicine, you can use it in anywhere. Yeah. Depression, anxiety, PTSD, addiction treatments, sleep disorders. I can use these techniques. Yeah. I have used these techniques. All right. Next. Specialties. Yeah. For any subspecialists over here, anyone that there is also a specialist, do let me know. Yeah. Do let me know that you are here, because I would be interested to run a research with you guys about using clinical hypnotherapy for this. Yeah. Gut any gastroenterologist, yeah, any dermatologist or pain specialist, because there are evidence that actually this works. All right.
After his session, if there is any questions, then we'll open the floor. Rodney, over to you.
Okay, thank you, Dr. Asha. Thank you, Dr. Thong, for such an insightful and informative presentation. Hi, everyone. Good evening. I'm Rodney, the Business Development Manager at the London College of Clinical Hypnosis Asia. I'm sure after listening to Dr. Thong's excellent sharing, some of you might be keen to learn more about clinical hypnotherapy. Please take note that we, LCCH, we do offer courses in clinical hypnotherapy from certification levels up to diploma levels. We have the medical diploma in clinical hypnotherapy course, which is designed specifically for medical professionals. And for those who are not from the medical background, not to worry, we also have a practitioner diploma in clinical hypnotherapy course. So we will be teaching you from the basics on how to practice clinical hypnotherapy in a safe and ethical way, on how you can use it on yourself, which is self-hypnosis, how you can use it onto others, and you also learn how you can implement it in your current practice or profession as well. So of course, for those of you who are keen in learning more about this course, you can reach out directly to me, either by call or WhatsApp. My number is displayed on the slide, 012-670-4540. Or alternatively, you can also scan the QR code which we have prepared for you. It will direct you to our website where you will be able to view detailed information about our programs.
This was the slide that most of you were waiting for. So for medical doctors who are actually in this session, so this is the QR code. So what you can do now, I'll display the QR code for 5 to 10 minutes. So you can actually scan the QR code here. So it will bring you to a form. So you need to fill in your details there. So what will happen next is my team will actually submit your attendance tomorrow into the MMA platform. So currently I've checked with the MMA and they're having some technical issues. So that's why they are not able to generate their own QR code. So if they have provided their QR code, you could have just scanned and, it'll automatically go into their app. But that cannot be done at the moment because of some technical issues on their side. So they have asked us to submit the attendance manually. So that's why we are providing this QR code to you so you can fill in your details and my team will submit on behalf of you manually tomorrow. So go ahead, everyone. You all can scan. And for those of you in meantime who have questions to ask Dr. Thong, please go ahead.
So false memory implantation, working with individuals with acute distress and trauma. Okay, this one, yeah. Hypnotherapy is not programming. Yeah. So one thing, a lot of actually this, a lot of people ask me this question. A very good question. Your subconscious mind is actually very, I would say, what is the correct term for this? Protective. Your subconscious mind is actually very protective of you. If the therapist during the session says something that your subconscious mind doesn't agree, I hope that you experience this so that you understand what I'm talking about. If your therapist says something that your subconscious mind doesn't agree, you will be you will be jolted out of the trance. You will be jolted out of the hypnosis itself. It's like they will actually wake you up by themselves. So I have experienced it myself. It is not a nice feeling, yeah. But it actually tells you that if the therapist asks you to do something that your subconsciously think that is impossible, you will reject the idea. Yeah. This one is a research by UMS. We are looking into a new form of depression where this depression nowadays it is started by the Japanese culture, Japanese kind of a social issue where there is this what we call this need that the patient started to very withdrawn from the society. They become spiteful, things like that, spiteful towards the society. So it actually was found out later that this is a form of depression. We are hoping to look at how we are trying to look at this in the Malaysian context. So if you are a Malaysian, if you can understand BM and BI, if you have 20 minutes to spare, please help me out over here. Yeah, to do this questionnaire, there will be an English and BM section. Both of them, it might sound familiar, a bit weird, yeah. But do answer both and try not to treat the BI and the BM both the questionnaires in like don't because you jawab BM then you jawab BI macam tu. Treat them separately. Yeah. View them as a separate perception. Okay. This is an effort for us to bring a new psychometric assessment into Malaysia from, actually this one comes from Japan. Yeah, we are trying to bring this from Japan. Okay, so thank you. Acute distress or trauma, if trauma, one thing that I do, this one different therapies, different idea. For trauma, I wouldn't go back towards the trauma at the first get-go. I would really be ensure that my patient is actually would benefit from going backwards. Yeah, going revisit the memory. If I find that beneficial, then only I do. If not, I would actually avoid that. Yeah. With so many psychotherapy, how do you typically structure is used in terms of session, the length and cost? Additionally, do you find any challenges in balancing the dual roles of prescribing medication and providing psychotherapy? Okay, to answer that, psychotherapy and prescribing medication, psychotherapy, all psychiatrists have to do it. Even prescribing medicine, also all psychiatrists have to do it. We do psychotherapy as a part of our clinical consultation. So the good psychiatrist will always have a psychotherapy session, can be done very quick during the session. Okay. And also I can do it like a standalone. Yeah. Like for, I think that one structure is used in terms of session length and cost. Usually the length is 1 hour. The hypnosis itself, the hypnotherapy itself is 30 minutes usually. And the cost, let LCCH be the one to tell you how much you can earn. Yeah. I will tell you, psychotherapy dia apa nowadays, it depending on the place where you want to practice, the cost may vary. Yeah, like in KL is higher, in other places it might be, you may need to lower down your cost. Sorry, cost, not the apa tu, not the price. Okay, cost. For hypnotherapy, you just need a chair. You just need a comfortable chair for the patient. Yeah, and also the environment itself lah. So there is no like very high cost punya, very high costing around there. So you can even do it online. I have done it online. Challenges in balancing a dual role. Yeah, that is what psychiatry do lah. Okay. Autism will be a bit difficult because communication. They have sometimes they have a different role of different way of thinking. Autism kids. ADHD, I do find it difficult as well because they don't sit still lah. So for clinical hypnotherapy, the autism and ADHD, in terms of behavioral management, it might be a bit difficult. But yeah, to answer your question, I'm actually looking at using neuromodulation. So yeah, I'm thinking of doing something else for them. For depression, starting to lose interest, things. How much therapy normally it takes before they can be okay based on depressive state of starting losing interest and social function. I would say everybody is different. It depends on a lot of factors in terms of like the therapy punya, whether the therapist actually can identify the problem faster, or even how bad the situation is actually there, the environmental factor as well. How much therapy normally it would take. I couldn't give a clear answer on that because there's for therapy, if we look at up to how many sessions that we usually conduct. Okay, for CBT, yeah, for depression, yeah, we are looking at 12 sessions or even 16 sessions, 12 to 16 sessions. Usually it would take that long. For dialectical behavioral therapy, yeah, when it comes with personality disorder, you will be looking at 30 sessions. Psychodynamics also, yeah, 20, 10, 10, 20, or even up to 50 sessions in psychodynamic can happen. For clinical hypnotherapy, yeah, I will say this. Clinical hypnotherapy is very operator-based, meaning that if you as a therapist are very good with your suggestions on how you structure them or even how you tailor them to your patient. I have seen this I think I'm the lucky one. Okay, one session. I have done this in one session. I turned the patient around in one session. So depending on how you use it, yeah. Usually it can go like up 8 sessions or even 10 sessions. How come? Like I said, is whether your patient dia punya subconscious tu, are you able to find that single apa tu, because in clinical hypnotherapy, something interesting that I found is that there is actually that so-called key. Yeah. No. I'm not saying that clinical hypnotherapy is like way better. It's just that clinical hypnotherapy allows me to look past the usual structure, look past the usual analytical issues of things. It allows me to go deeper and look at what is actually beneath all this so-called issues macam tu. Yep, thank you, Dr. Tui. That is the answer. Rapport and ready to change, it works faster. So this is my contact. Do feel free to contact me if you have any questions. Yeah, if you wish to do any research. Yeah, I'm a researcher as well. This is my contact number. Yeah, please do not contact me after 12 o'clock. Yeah, so yeah, the usual ones lah, the usual courtesy part. So thank you everyone. Okay.
Thank you. Thanks, Dr. Tang.